Good morning, everyone. My name is Betty Ann Potriff, and welcome to the webinar on understanding and responding to trauma in our service delivery system. The Interministerial Committee on Child Abuse and Sexual Exploitation, which I co-chair with Natalie Huber, recognizes that trauma has an impact on children and adults in their lives and wants to support service providers to understand more about how to respond to trauma. Excuse me. I'm therefore very pleased to welcome Nancy Poole of the BC Centre of Excellence in Women's Health in Vancouver, who will be speaking to us today. Nancy has recently led a system change initiative towards trauma-informed practice for mental health and substance use field in BC and is currently facilitating the development of practice guidelines for child and youth services in the BC Ministry of Children and Family Development, along with many other projects and involvements that I'm not referencing. She is in high demand across the country in the area of trauma-informed work, so I really appreciate her taking the time to do this webinar in Saskatchewan. She's facilitated a number of events in Saskatchewan in the past, and some of you may be aware of her work. Nancy is also known in Canada for leadership in piloting online participatory methods of knowledge exchange, such as we have today. And with that, I'm very pleased to say that we have Nancy at this session. I also want to acknowledge that this session is supported by funding from the Drug Treatment Funding Support from Health Canada, and we're really appreciative of that. So Nancy, with this, can I just turn it over to you?
Great. Well, thanks a lot, Betty Ann. It's a pleasure to be here speaking to you folks in Saskatchewan today. Dear to my heart, Saskatchewan is. I lived in Saskatchewan for 8 years, and as Betty said, I've had lots of opportunities to do some education in the past couple of years on this issue. So today we have this 2-hour session of doing a kind of a intro to trauma-informed practice. I'm going to try and cover these 6 areas that are on the screen right here now. And I just want to really caution you that, you know, some of it will be really relevant to your work and some of it may not be quite so closely relevant to your work. So just choose what makes sense for you, because we're trying to reach a really wide range of audiences with this, and it's hard to tailor it perfectly to what your needs might be. Now, we are going to have these slides and a recording of the session available after the 3rd of these 3 intro sessions, so at the end of April, and they'll be on the website of the British Columbia Centre of Excellence for Women's Health, and we can put the link to that or where the website in general is right now in the Q&A session there for you, so you can see where that ultimately will be. So don't worry about taking notes and whatever. It will ultimately be available to you. And speaking of the Q&A part, after each of these, 6 chunks here, I'm going to stop for a few minutes and answer questions that people have. So I really encourage you as we go along to type in your questions in the bottom right-hand corner, and I will pause and answer as many as I can as we go along. There's also the opportunity, we'll probably send you a little quick survey following this about the success of it or lack thereof, and there'll be opportunity there for you to add some more questions if you have them, or ideas of where you think all this education on trauma-informed practice might go from here. So let's get started on the foundations. I always like to start the presentations a bit by locating myself, and I've done a bit of work on this, as Betty Ann said. I've edited this book for the Centre for Addiction and Mental Health in Ontario, and I've led the development of this guide in British Columbia as 2 sort of print materials that I've done, both in collaboration with a very wide range of people who have helped me think through what is is it to do trauma-informed practice, and how are they applying the principles in the context of the work? So you'll have the benefit of their wisdom as we move along today. So how did we get here? We got here because really a lot of systems of care have been interested in trauma-informed practice, so that it really is, I think, an issue without one home in lots of ways. So on the slide here's pictures of work that's been done in child and youth on trauma-informed practice, in the homeless sector with pregnant women who use substances, and in the larger BC mental health and substance use system. And that's what I think is so amazing and important about this work, is that it is multi-system work. And I'm going to talk a fair bit about that at the end in terms of the linkage across the many sectors who have a possible role to take up as their social responsibility in this. Now, we got here by a lot of really great people doing work to bring this issue forward of trauma. And one of the most important of these is a study done in the U.S. in the public health sector on looking at the long-term impacts of adverse childhood experiences. And I think that, you know, this has really changed our thinking about the importance of working in a trauma-informed way, and to recognizing how adverse childhood experiences can lead to disrupted neurodevelopment, a lot of other, you know, delays and impairments, adoption of high-risk behaviors like substance use, and a whole range of chronic diseases, including addictions problems and other things. So if we're starting to see these things like later life diabetes and later life substance use problems from this lens, it shifts a lot about what we do as service providers. At the same time, there's been a lot of work done by women's health advocates on these issues. And, you know, the hallmark book by Judith Herman, the Trauma and Recovery book, really helped as early as 1992 establish for us that there were important different time frames and sequences of recovery from trauma. And the first one, and the most important one for the issue of trauma-informed practice, was the establishment of safety prior to doing any other level of work. And the other thing that she brought attention to was the fact that many women do have substance use, mental ill health, and trauma issues that are linked to their experiences of intimate partner violence or gender-based violence. And so made a lot of links to say, you know, trauma is not just something that happens to Vietnam veterans, but really is something that's being experienced by a wide range of different groups in our society that we really need to attend to. The third group of people who've made an amazing contribution to our understanding of trauma and the importance of trauma-informed practice are people working on Indigenous health, and have really helped us understand the very particular form of trauma that Aboriginal people in this country have been exposed to through the experience of residential schools and other forms of historical trauma, resulting in intergenerational traumas, and have really given us a lot of insight into what it is to heal using Indigenous wellness and cultural safety methods. And finally, the fourth real contribution, I think, that has brought us here to this moment of saying, why do we need to act on trauma-informed practice at this time, is all of the folks that are working on neurobiology and explanations of how disruptive attachment can result in these later life issues. And particularly, they focused on early attachment, but many of them also are offering a lot of interventions like Pat Ogden and others around how might we help people self-regulate, building from a somatic and cognitive approach. So we have all these wise folks from all these different areas really contributing to the understanding and the practice of trauma-informed practice. So we're bringing in all we know from these different disciplines, and we're starting to think about what does it mean in our interactions with our clients, in our service cultures, in the way we work with each other across systems, and how we address trauma and violence at the larger societal level as well. So that's kind of where I'm starting from as a foundation in all this work. And I'm just going to pause for a minute here and see if there are any questions so far. I don't see any so far, but please continue to think about typing in things as we go along. So, the second section here is a little bit about understanding trauma. So let's have a go at that as fundamental to trauma-informed practice. So first, some definitions of trauma, and this is one from the Substance Abuse and Mental Health Services Administration in the U.S. So they're talking about trauma as resulting from an event or a series of events or a set of circumstances that's experienced by an individual as harmful or threatening or overwhelming that has these lasting adverse effects on functioning in a whole range of areas. And many of you may be well aware of this idea of, when we are overwhelmed, how this can ignite a fight, flight, or freeze reaction at the time of the event. And so really puts our nervous system into a bit of overload. So you'll notice they're not talking about trauma as the event itself, but as the result of events that people are exposed to and people's reaction to those events. Here's another definition of trauma that some of you may be more able to connect to. It's a bit more of a social version of definition of trauma, as experiences involving disruption in trusted relationships as a result of violence, abuse, war, or other forms of oppression or uprooting or dislocation from family or community or heritage or culture. So you can see in both these definitions, there's things about damage to core relational abilities that we as service providers and service systems need to be thinking about. So here's a whole range of the actual traumatic events that people may have reactions to. And I was just in Alberta yesterday, and people were talking about, the impact of the flood in southern Alberta and the wildfires in northern Alberta as definitely something in the trauma experience within the Alberta folks. But here's also lots of other ideas about accidents, oil spills, as other kinds of events that can evoke a trauma reaction. And also the ones we're more aware of, like sexual assault and warfare and domestic violence and sexual assault, home invasion, bank robbery, all these kinds of things can really, set off trauma responses, as can these larger group traumas like that experienced by Aboriginal peoples in Canada. And so you can see this can be something that happens at the interpersonal level, at the developmental level as a child, or as a political or system-oriented experience. So really a wide range of things can be involved, but of course not everyone will be traumatized by those events, and reactions amongst people will be different. Some people will develop post-traumatic stress disorder, and this is, a particular mental health diagnosis that is associated with the experience of trauma. But it is not the only, thing that happens as a result of trauma or that may happen as a result of trauma. It's really also quite common that people will experience depression or anxiety as well. So it's important to recognize really the wide range of effects that can result from trauma. So they can be physical effects like headaches and sleep problems. They can be emotional ones like depression and anxiety and dissociation and just being overwhelmed by memories, etc. They can be spiritual in that sense of loss of connection to self and family and culture, with a lot of self-blame involved. They can be interpersonal and or behavioral, like substance use. And that may be because there's such a wide range of effects from trauma. It may be why, we've come to this place so far of not really recognizing how central it is to people's health and not put in place the kinds of trauma-informed responses that we're now aware it would be a good idea. So another way of thinking about trauma effects can be, by thinking about it from the more medical model approach, the diagnostic approach of the diagnostic manual that is used by psychiatrists and psychologists and others, and thinking about the symptom clusters that characterize post-traumatic stress disorder. So people who've been exposed to trauma and have PTSD may have memories, nightmares, flashbacks, those kinds of intrusive responses. They may also have what the grouping of symptoms that they call the avoidance ones, where people avoid people in conversations and situations and are quite isolating. They may also have arousal type symptoms like being irritable or hypervigilant or difficulties with concentration. And finally, they may have the negative mood kinds of symptoms, such as being detached or feeling numb, being depressed, and not being hopeful, etc. So, lots of ways, I guess, of thinking about trauma effects from, different locations and different types of services. And you may, choose to describe them in different ways depending on what type of work you're doing and what system of care. But the thing that's interesting is that I think is that there are very predictable response patterns in the brain resulting from extreme threat. And here's where the neurobiologists and neuropsychologists and others have really given us lots to think about in terms of understanding reactions to trauma as being on this continuum of fight or flight or freeze and surrender. And that different people will, react to trauma in different ways on that continuum, and really started to help us understand it from a more biological level, to really understand, how is the sympathetic system within our body managing this exposure to trauma. Are we able able to stay within this window of tolerance, this optimal arousal zone, or are we, pushed into either the fight, flight, or the freeze type of, or numbing types of responses? So you can see that when things overwhelm us and take us out of that optimal arousal zone, we may be overloaded, have a lot of emotional reactive responses, racing thoughts, impulsivity, etc., or it may go in the other direction where we become more numb and slow down and not as able to process things. So this is just kind of giving us a little bit of a technical picture of what that response looks like from the high or low activation of the stress response. And, you can imagine then just how problematic that can be when that kind of overwhelm happens when you're very young, and that early dysregulation of your stress response system doesn't really allow you to self-regulate or learn how to find a place of peace and in that window of tolerance. And that in that case, this kind of chronic stress can result, and people can spend their lives having a very difficult time managing these sequelae of exposure to trauma. So lots to think about in terms of what it is. Now, there's also the issue that we in our services may see someone experiencing a response or be re-triggered within our services, and it may look like this with someone coming in to our services. You may notice as you're talking to them, explaining your program or whatever else, that they are flinching, or they appear to be shaking, or staring off into the distance, or in some way or another being overwhelmed, even as we're doing something which seems fairly innocuous. And I think this is an important part of our work on trauma-informed practice, is really to notice this and to help people calm and to take some time on that. And I'll talk a bit more about that later, but for now, I guess I just wanted to say that I really feel that what's important for us to get is that there are implications of people being exposed to trauma, and this is what we may see in terms of people coming for help in the whole range of justice or violence or child and mother-child services, etc., is we may see people coming who have a real difficulty with trust and relationships, who are reluctant to engage, who may be quite vigilant and suspicious, who may have had previous experiences, of being triggered or re-traumatized in our systems, and and many of you working in the addictions field can recognize this one, may have real ambivalence to give up. Hi, Doug. Oh. May have real ambivalence to give up or change their coping mechanisms. So really important for us to get this and not see them as difficult or impossible clients who shouldn't access services, but to really think about what do we need to do to counteract this in ways that aren't necessarily about treatment of trauma, but are about really supporting connection by people who may have had trauma histories. So just to sum up this, quick overview of what is trauma and what it looks like in the context of services, is this slide just from Lori Haskell, really emphasizes this, that, many survivors and service providers can misunderstand people's difficulties as somehow self-inflicted because we don't understand how abuse and trauma and their effects reverberate throughout a person's life. And we tend to see them as making bad lifestyle choices rather than seeing them as coping as best they can. So that's part of our work, I think, in going forth. So what do we mean by trauma-informed then in the face of all this? And this is the 4 R's of trauma-informed from SAMHSA again, that I think says it really nicely. That trauma-informed services realize how common trauma is and that there is hope for people to move forth from experiences of trauma. Secondly, they recognize the signs and symptoms of trauma in the clients and family and staff and others who are involved in their system. They respond by fully integrating knowledge about trauma into policies and procedures and practices and really work hard to avoid re-traumatizing people as they come for help. So trauma-informed services are really not at all about treating trauma as much as they are about building into our work the recognition of the fact that trauma may be in place and not requiring disclosure of trauma as much as building in a lot of different ways in our policies and practices to honor the fact that this may be going on for a large proportion of our clients. So I'm going to stop again for questions, and I'm not sure here. I'm not seeing any questions that aren't other than about audio so far. Is that correct? It looks that way to me from my thing. I'll just mention these 2 things that are on the screen here now are things that we're just piloting in BC right now in terms of thinking about how we could have various images and information about trauma posted in our services that bring attention to trauma in a way that's really helpful to people coming to access services. So we haven't finalized these at all. We're just kind of piloting them right now. But you can see that the one on the right just tries to give a bit of education about the effects of trauma, and you can't really read it there, but it does talk about how trauma is common and it affects everyone differently, and there's hope in terms of healing. And the other one is giving some examples of helping people calm themselves with a whole bunch of different grounding activities. So yeah, these are things that we're working on designing and doing in British Columbia right now. Alrighty, so let's move on to what trauma-informed practice is. And, the thing that's really interesting about it is some people think, well, I'm looking for a set of techniques that's going to make a difference. But really, trauma-informed practice is about applying some principles of practice within services. And I really encourage you as we go through this next section to think about your own service system or your own agency or your own workplace in terms of how might these principles of trauma-informed practice be applied in our workplace. And in some ways, I think it's a really important new direction for us because it's not a set of techniques that somehow has been designed in New York or, Toronto or anywhere else that everyone should comply to, but this is something that is very contextualized work that you need to think about in terms of who are our particular clients and families and staff and co-workers, and how might we bring this into our particular realities. So I'm very interested in your questions and thoughts as we get to the end of this third section about principle approaches. So everybody has, a whole series of principles have been proposed. Here's the ones that have been proposed by the Substance Abuse Mental Health Services Administration in the U.S. First of all, that we think about safety, and as I mentioned in Judith Herman's book, that is something that is really extremely important that we think about in terms of people who've had experiences of trauma to create safety. Trustworthiness for people whose, boundaries have been violated and have been overwhelmed by something that wasn't in their control, to create an entirely different experience of trustworthy service providers is really critical. The idea of collaboration, when you've been in a situation where you have been powered over, to have a situation where you can contribute to your own care in a more collaborative way and have an experience of a reparative relationship is really important. And that idea of choice, creating choice within the context of our services, small or large. Would you rather have appointments in the morning, or is the afternoons better for you? Even small choices like that can make a big difference. I think always we have to be reminded that this is something that we need to involve people in their own care, and involve peers and families and co-workers in. And we always need to be conscious of the cultural, historical, and gender issues at play in this work. And I'm going to do a whole section here talking a bit more about the cultural and gender lenses on this. But let's just walk through these principles a bit. In order to apply these principles, I think we need to start with this idea of trauma awareness, that all of us need to do things like this session today, where we get more aware of the prevalence of trauma, how it can be central to people's development, that people make a really wide range of adaptations to cope and survive and have a wide range of impacts on their lives. And they may end up, feeling depressed. They may end up with substance use problems or chronic pain issues, whole range of things that we need to see beyond the presenting concern to how what's happened to them may be at play in the context of this work. So that issue of keeping ourselves aware of the developments in the field of trauma, I think, is extremely important for us. The second thing is that idea of safety and trustworthiness, is really getting that there are things we can do to create safety and be trustworthy as service providers. And that can be, from improving our intake procedures, adapting our physical spaces, really being conscious of how we provide information about programming and are predictable and fair in the context of our programming, that we're always conscious of safety and that people have safety plans, etc. So safety and trustworthiness being really important. Just want to emphasize, and I'm going to spend some time at nearer the end on this part of it, but safety and trustworthiness also very much applies to us as service providers as well as to the work with clients. That, the exposure to people with trauma histories can make it quite challenging for us as service providers, and we need to consciously think about what is safety and wellness for us, and to create service cultures that support that. And this one, for me, is really the core of it in lots of ways, is this idea of choice and collaboration and connection, that moving from this kind of sense of we know what's right for you to the place of really communicating more openly, equalizing power imbalances, allowing expression of feelings, providing choices, and working collaboratively. Just such a different approach to the work that we've often been doing with the service provider as the sole expert rather than part of the team, that can make such a difference to people's ability to engage and to stay connected to services, or to, alternatively, just to feel traumatized by being once again told what to do and not have any agency in the context of health improvement. And the final piece is something that is related to those images about grounding, etc., is that it's really important for us, I think, to teach resiliency and coping skills and to model these in the way we work with people, and to really make that part of an organizational culture of learning together, being emotionally intelligent, and creating, and making the path by walking it, as Paulo Freire would say. And I think this part of it is extremely important. And it's not, I'm not suggesting that we do the kind of treatments that are some wonderful treatments for trauma that mental health practitioners and would do, and some people may need that, and we may want to be referring people on for that kind of help. But there's a lot of very basic things we can do in terms of teaching resiliency and coping skills as a principle of practice. And just wanting to mention, how important this is, that these trauma-informed approaches, how they open up spaces, I think, for us to hold really challenging conversations about intergenerational trauma and racism and colonization and issues such as very specific forms of trauma, whether that be sexual abuse, or whether that be other forms of exposure to trauma, that the trauma-informed lens gives us more room to have these kinds of, or language and principles from which to work that can really create safety for people of all cultures and of different experiences and exposures to trauma. So I think it opens the door for us to work in culturally sensitive ways, in ways that perhaps we haven't seen before, that trauma can be a kind of a common language for us to work from as we have conversations that are intercultural ones. So, you know, I think the really important part of our work is to think about how trauma responses can really affect people's ability to have trusting relationships. And we need to compensate for that in the kinds of service provision that we do. And that most importantly, we need to recognize that we can do trauma-informed work without requiring people to disclose their trauma histories. And quite often in the past, people have complained about the number of times they went to services and were required as part of intake to tell their entire story about trauma, and that hasn't felt safe to them, and it hasn't been something that's been helpful, and that there are ways for us now to think about working in a trauma-informed way that doesn't require disclosure, but practices these kinds of principles as a kind of a universal precaution, as opposed to individualizing it, but saying, you know, because it's common that people accessing our services may have histories of trauma, we'll start by working from these principles. And as time goes on, if we come to the place where it is, you know, the person does disclose, or that it appears that they could benefit from treatment, then we'll do that as a second phase. But first of all, we'll create safety and relationship and ensure that we begin a process that's entirely helpful and not re-traumatizing. So that's, you know, a really important part, I think, of how we do this work in general, and shift our thinking from seeing people as having problems as much to seeing people as having stories that may make, you know, them less trusting. And instead of seeing them as kind of controlling or uncooperative or attention-seeking or all these other words, we could really shift our language in the way we work with people to, you know, be thinking about how this may be an attempt to cope. So rather than seeing people as manipulative, we see, you know, we reframe it as this is a person who has difficulty asking for what they want, etc. So part of trauma-informed practice is really thinking about how trauma may be at play in the way people are presently expressing themselves to us in our services. And there can be lots of ways for us to begin that conversation to help them build awareness of how they're responding. And there are things like this simple pamphlet from the Centre for Addiction and Mental Health in Ontario that I really recommend, that explains trauma in very simple terms of how it can affect your feelings and your physical health and your sense of being able to concentrate, etc. Really great thing that may be helpful with some clients in terms of beginning a conversation and making links between trauma and other things that are going on for them in their lives. In British Columbia, when I've done some of the work, one of the things that people have said has been really helpful is in terms of applying the principles, has been to think about how do we create safety and engagement at the time of intake, that this is a really important step in the process of becoming trauma-informed, is thinking about creating safety, engaging, not starting with long intake forms as much as starting from establishing a relationship and focusing on what's presently, you know, of concern, normalizing client experiences, setting boundaries, and identifying people's current symptoms, such as trouble concentrating, as opposed to asking for long trauma histories. And, you know, that carries over into early interactions that we may have with clients in terms of providing clear information about what to expect, giving choices, explaining why why the service is set up in the way that it is, giving lots of opportunity for people to ask questions, and being ready to respond to people who may be arriving or may be triggered as we do early interactions, and be prepared to pause and help people self-calm and regulate. And lots of ideas people have had on, you know, applying trauma-informed practice in the physical environment and, you know, changing the way waiting rooms look like, really thinking about accessibility and choice in the counseling rooms, whole range of ways of making this a place where people who've had trauma histories may find it much more welcoming than a lot of locked doors and having to yell through a little plexiglass hole about what your problem is, etc. So really shifting the way we work at that level. So just to finish up this long section, I understand it, on, you know, applying the principles, just wanted to mention one example of applying the principles in a children's residential mental health center, where they did these following things to be trauma-informed, as well as doing their trauma-specific work. They helped people identify triggers, what makes you upset. They noticed when people started to be distressed and the precursors of distress, and helped teach that and discuss that. They taught a whole range of self-calming or sensory modulation techniques like grounding, etc. They helped people with thinking skills and with choice-making skills. They promoted that as part of what they're doing there, as opposed to just being recipients of care, that they were actually making choices and thinking about learning how to think clearly. And really lots of opportunities for relational development, learning to connect with service providers and with other people in the program, and doing lots of wraparound with services that are connected to children's services themselves. So, you know, there's an indication of somebody who's not actually, you know, a community-based services, but quite a complex service, who was able to really see ways of applying the principles of trauma-informed practice even within the context of that more in-depth care within it. So I'll just stop again for questions here and see what people have to say. Yes, very similar to the response to unresolved grief. And there's a lot of connection being done, and often I include unresolved grief or sudden loss as something that is an experience that evokes trauma. And there's quite a lot of work being done on making the connections between the people working on grief-related issues. I was just in Alberta yesterday, and there was one person from the session there who was specifically looking at supporting people through some of the challenges related to divorce and loss of custody and those relational losses and grief and the experience of trauma. So yeah, great to make that connection. So here's a question of, are you suggesting that ongoing trauma is primary? And I'm suggesting it may well be in many more cases than we've attributed it to in the past. And I guess I'm just saying that given that its trauma is central to many people's development, it does really require us, I think, to at least put in these simple or yet profound front-end precautions or universal precautions and ways of working, given that that may be the case. And to work with the person to understand just how primary that may be in each individual case. But I guess I'm making the assumption that it could be primary, and therefore we need to think about different ways of working than perhaps we have. Any other questions here? Yeah, the question of references and resources, I'm quite prepared to put up, as well as the slides themselves. I have just been reading so much from so many fields where this work is being done, and I think there's tremendous quality work being done, a very specific, application of these principles in a range of settings, and I'm quite happy to share the different resources I've run into and the links to them as well. And as I've been going along, I've been creating little sheets of resources with online links to them in this modern world. So I'm happy to provide that as well as the slides on the site. Yeah, the idea about how an organization could facilitate providing choices to clients, I think that's a really interesting one. And, in some ways, I would think that the best people to ask that question of would be a selection of your former clients or current clients, and get some ideas from them as much as from me. But I think one of the things that really stands out for me in terms of the choices part is that I feel oftentimes in the past we might say something like, as people are thinking about services, and we might say something like, well, here we offer support on substance use problems and support on housing, getting connected to stable housing, and whatever else that you offer. And then we'd say, we think that creating choices is, and what else would be important to you? And sometimes I think that is almost too open-ended a question for some of the people coming for us who may not feel like they understand what's safe to ask for or what's even possible to ask for. So, it might be an idea to think about saying, some of our clients also find it helpful to have an evening session on reproductive health or birth control or whatever way you might say that. And others find this and that, so that you're actually naming what some of those other choices might be, and you're normalizing what some of those other choices might be, et cetera. So I think that's one idea in terms of answering that sometimes we might not think about. I did a study in British Columbia in a psychiatric facility there, where I asked the psychiatrists at the at intake to this mental hospital to ask the clients this choice: when you get upset, what do you prefer? Do you prefer to be in a, have the opportunity to be in a room by yourself where you can calm down without a lot of stimulation around you, or do you prefer to stay out in a, in a common area where there are others who can, help you calm down? And it was, to me, that's just kind of an interesting choice about your treatment is more of a choice around how might we handle you when you get upset. And when I interviewed the patients later, they said, it meant a lot to them to be asked that question. Two things were important to them. One was that the psychiatrist used the question when you get upset, not if you get upset. So there was already that idea that it was okay if people, got upset in the context of their care. And secondly, that idea that, they cared enough to really understand what would be your preference. And you can see that's not a very big preference, but it's certainly a small choice that can be implemented and can mean a great deal to someone who may have had a trauma history that involved being locked in a cupboard or left alone or whatever, and that, being secluded may be the very least helpful thing to them. So, those are just a couple of ideas about creating choices within that in terms of preferences. Just going down the questions here. How would you adjust tips for clients who are not necessarily in safe environments, such as jail, where you can't adjust the environment? Yeah, that's an interesting one. And I know that some of the people at the Burnaby Correctional Center in British Columbia have been taking on that particular one. And I don't know what their answers are totally. But be glad to try and find that out, or you could connect with them as well, because I think that is an interesting question. One of the things that I've been doing with Dr. Dell, Colleen Dell from Saskatchewan, whom many of you may know, is working on this idea of using dogs as trauma-informed interveners in the context of people in correctional centers who have serious trauma histories, as a way of not changing the physical environment in terms of what it looks like, but what's available as kind of supports for self-calming and learning connection, etc. And those of you who know those dogs, the St. John's Ambulance dogs, therapy dogs that she's been working with, Annabelle and Subi and Kisby, and I think it's a really interesting way of humanizing a setting like a jail, and giving opportunities for people to connect at a very basic level that isn't therapeutic as much as it is trauma-informed in lots of ways. The chance to sit calmly and connect with these absolutely adorably ugly bulldogs and whatever, it really levels the playing field in lots of ways. And Susan, I see there's something from One Arrow First Nation Health staff, and yeah, I've been collecting a fair bit of material on the work Indigenous approaches, and be glad to share that with your group. And at the end, I think is my email, and I'd be happy to have you connect with me to get those, because it's so important, I think, in the context of your work to be working in this way. Yes, there's lots of solutions around jumpiness or sudden jerkiness, and that's getting a little bit more into the area of treatment for trauma. And I think learning some mechanisms for self-regulation can be really important to people who have that, hypervigilant type of response. And it's not something I can really cover here, but I'm happy to make you aware of some of the resources that may be available in Saskatchewan to be working with people to teach self-regulation around that. But it's so funny that you mentioned that idea about how those coping mechanisms can really get in the way of people being able to have positive relationships. So great that's there. I think what I'll do is carry on with some more of the presentation and come back to the questions as we go along, because we may not get through through it all otherwise, because we're halfway through the presentation now. But I really appreciate these great questions, and we'll definitely see them as important ones to be responding to. I wanted to give you a few examples of how people have enacted trauma-informed practice in their different settings, and maybe this will be a bit inspiring to you all as you're thinking about the application to your own setting. As I mentioned, in terms of how do you think about treatment choices, I think we should always be thinking about starting from asking our clients about how best to bring trauma-informed practice into our services. What is safety? What do they experience as safe or triggering? And really involving them as Jennifer says here, as full citizens in their treatment, in her case, for mental health and addictions issues. And I think, this principle, which, lines up with a lot of different good practices, not only trauma-informed practice, is a really important one for us to begin from. The next field I just wanted to mention is also something that's come from Saskatchewan, a really excellent handbook on sensitive practice for healthcare practitioners, with a whole range of suggestions for primary care type people in terms of how they can bring trauma-informed practices into their settings. And if you are from the primary care area, I really recommend this this resource. The homeless field has contributed more than almost any one field to our understanding of what trauma-informed practice might look like, perhaps out of desperation in homeless shelters that serve a lot of people with trauma concerns, current and past and cumulative. And, some of the evaluation results from those different initiatives within homeless shelters have been extremely positive. There's been high levels of support for shifting to a trauma-informed way in the programming, and it has really made staff more confident. It's reduced the number of resident conflicts and created much less kicking people out by working from it. That particular model, The Shelter from the Storm is an excellent resource, as is the one beside it. The toolkit gives a lot of great ideas about applying trauma-informed work in more open-ended settings like homeless shelters. But here's an example of people having applied trauma-informed within child welfare practice, and this particular manual unpacks every stage of the child welfare practice and child protection work, from start to finish, really honoring these important pieces along the bottom that I think are such a sign of great trauma-informed practice. The idea of maximizing safety for children and families, really thinking about what are the trauma-related needs of children and families. And in the case of children, I think they need to, assess for trauma, and help with self-regulation is way more present than possibly for adults, where that can be in a more paced process. But look at these central things here. They're concerned with enhancing child well-being and resilience. They're concerned with enhancing family well-being and resilience, and the well-being and resilience of those working in the system. And I think those three things of thinking about the client's support system, and those working in the system is all fundamentally important in trauma-informed work is really important. And the two on the other side, the partnering with youth and family, and partnering with other agencies and systems to deliver this. I think, these little line of boxes is a perfect statement of trauma-informed practice within a system such as child welfare. And for those of you working in that kind of a system, really recommend this resource from the Chadwick Group in the San Diego area. Just another example of working with families and that idea of children and families. This is a particular intervention that is, I think, entirely trauma-informed. It starts with a phase one that is all about safety and helping people meet their basic needs, and then there's a phase two where they teach family psychoeducation and emotional regulation and building of relationships, and then finally a third phase that has a family shared meaning of trauma and a closure level, all working through this idea of reflection and transparency and collaboration. So just an example, I think, of how we can design any intervention that we do, focusing on these stages of safety first, teaching of skills, and creating choice, and helping people shift to a whole other understanding of their circumstances. This is an example of something that I saw at a conference 2 weeks ago in Toronto, where the Registered Nurses Association of Ontario had actually thought about how to integrate trauma-informed care into smoking interventions. And it has a series of questions in this booklet that helps people who are doing smoking interventions with pregnant women smokers, and asks a series of questions that helps them emphasize safety, build trustworthiness, maximize choice, collaborate, and empower. And I just thought it was such a nice idea to see how, trauma-informed practice can apply even at the level of an individual substance intervention as well as in the whole system. So here's an example of a psychiatric unit setting, which I just included not because many of you may be involved in psychiatric units, but I thought it was such an interesting example that this Oregon hospital, how they interpreted trauma-informed practice. So here's what they incorporated: daily meetings for problem solving, not using labeling of people by their disorder where possible, doing the intake in a comfortable room with family members present instead of in a locked unit via an anteroom where you're escorted by security, involving clients as full participants in planning and decision-making for their own treatment, and lots of energy put into staff learning to hone their own coping skills and therapeutic skills. And in so doing, they saw a reduction in seclusion and restraint in this or traumatizing, things by 87%. So I just think, again, it's just a really clear idea that this is not rocket science. These are very pragmatic things that can be done in any service and which can be thought through in terms of how it applies in any setting to create safety and empower, be transparent, etc. And this was an example of a community-based group that I worked with in Victoria. I did an evaluation of this particular Seeking Safety group, which is a model which has been developed by Lisa Najovitz in the States, a wonderful model about that's sort of on the continuum between trauma-informed and more trauma-specific intervention. But it was an outpatient group run by a trauma counselor and addiction counselor, and they had two parts to it. A first part, which was called Seeking Information sessions, which they added to the front end of this group model, which I thought was entirely trauma-informed, because they said, come and do 3 sessions on learning coping skills first at your leisure, and once you've done that, then you can make the choice about whether you would like to attend the Seeking Understanding part of it, which is a more in-depth examination of topics related to trauma and substance abuse. And so you can imagine what happened was that some of the women came and went to the Seeking Information sessions, and after that said, you know what, I don't actually think I want to do the whole group. Now, I want to go out and practice these strategies for a while and then make a decision about whether I want to do treatment at all. And then over time, they actually narrowed it down where they actually did the 12-week group as 2 6-week sessions, so that at the end of 6 weeks, women made another choice about whether they wanted to continue for the second 6 weeks or whether they'd had enough for now. And you can imagine, adding in these kinds of trauma-informed principles to this work really meant that women got what they needed, felt empowered, and didn't feel the need to drop out because they'd committed to more than they could actually manage at the time. So it, is a win all the way around in implementing trauma-informed approach. Lots of work has been done in juvenile court settings as well. I knew that some of the people coming to these sessions were involved in the justice system, and just really want to mention that lots of things have been written on the issue of trauma-informed practice within justice settings. And people have thought about how they can educate judges, work with Crown advocates and attorneys, and really bring this kind of idea of what might be helpful in bringing a trauma lens to those settings. And last but not at all least, I just wanted to mention a particular example of trauma-informed practice in action in a pregnancy outreach program designed for Aboriginal women. This one is in Winnipeg, called the Mothering Project, and I recently co-presented with them at a conference, and they used this slide to describe some of their work, and I just thought, man, this is like a wonderful statement of trauma-informed practice with, the women involved in the program development, the things like the cultural interventions, the drum group, the low threshold intake process, the valuing of women's understanding of what's helpful to them, and lots of work around trauma-informed tools that they saw as being helpful, including gardening, food as medicine, trauma-informed yoga, and mindfulness activities. So lots of great work. They also were very much aware of the importance of the whole system being trauma-informed, and really worked a lot on interdisciplinary collaboration and navigating the system with women. And I just like their overall statement that they're oriented towards kindness. Is a really nice way of summing up what they're doing. So I'm going to stop there before I do this next section and ask for and have a look at what kinds of questions have come up as I showed those different things. Yeah. I'm not an expert in interventions with young children, but I know lots of resources that are, lots of people who are, and yeah, I don't, I think, you know, that idea of what your preference is with children may well be one where you give the two answers and you know, or however many options you're giving, and really see what happens from there. And I think, you know, when children are really young, the importance of involving their caregivers, whether they're their birth or foster or other caregivers, in helping answer that question might well be part of it. So yeah, challenging to think about how we create choice and safety within the context with very young children. Yeah, this is the challenge, I think, that you've mentioned in this next point or comment, kind of, Chris, about, you know, having choice and voice conversations really requires that you have a system of care that can make room for that. And I think that is exactly where we're heading here in the section 6, is that you cannot put all of this work on the back of practitioners when systems of care don't support trauma-informed approaches, and, you know, giving time to build relationship, for instance, before you have to fill in intake forms, etc. And I think, you know, that is the whole point that we need to get in trauma-informed systems of care, is that it's counterproductive and not evidence-informed for us to start off by grilling people with a bunch of questions when that is not something that is possible for them to answer without having built some kind of sense of safety. And, you know, I first became really aware of this in the context of the work we do with pregnant women who are using substances, and the prevention of FAS is that people felt that it was really important to start with, how many drinks do you drink a day? You know, like, just without even establishing some sense of safety for women to be able to tell, and what are you going to do with that information? Does that mean that I'm going to lose, I'm going to be reported to child welfare and stand to lose custody of my kids? And, you know, so this whole idea of having systems that support flexibility and really allow us to build relationship and teach people how to cope with trauma, and don't judge them for substance use problems in ways that are really unhelpful, I think is really exactly what trauma-informed systems of care need to be. And that's why I'm kind of recommending that leaders at all levels and all levels of service providers, including receptionists and as well as practitioners, really engage in conversations about how can we adapt these things that we do in order to not make it more difficult for the people that we serve. So I think, that comment is entirely important, and that idea about collaboration and learning together is completely critical. Can I talk about TIP and children and youth in a school setting? And all I can say is on that today, within the limits of the day that we have and the time that we have, is that there are a number of articles that I can point people to that talk about trauma-informed schools and how schools have changed the way they work to be trauma-informed and adopt a whole school approach to trauma-informed practice. And in the course of that have ended up with a lot less kids kicked out of school, a lot more kids connected to the kinds of supports that they need. So it is applicable within the school setting, but way too big a topic to take on in the context of these questions and answers. But yeah, interesting, how so many systems have been grappling with this. There was one more question here that I skipped over the first time from James that I'll just go back to now for a minute, that was about families with a history of trauma as frequent users of many human services. I showed, I think, a few examples of family-specific TIP best practices as I went through that second section, but I think it's really important that we get that people may have had really a lot of different connections to services, some positive and some not so positive. And that idea of connecting up our services into a net of support that are all working from a trauma-informed approach is a really important one, and will save, I think, a lot of time in many services as people are able to not necessarily retell their story every time, but definitely help sort out amongst services what is really helpful and what could be worked on together and apart. I think it's especially difficult where the trauma is actually within the family, and one of the family members is the perpetrator. And I think that's the challenge that takes a fair bit of thinking through as a system about how all of us can contribute to the health of the family in different ways, and we can really improve services and understand even perpetrators through the lens of trauma-informed practice. So lots for us to think about in this process. So speaking of perpetrators, which in the case of violence against women are often men, I think that it's important for us to really take on this idea of how might trauma be different and trauma-informed practice be different for men and women and for people of different cultures. And I just wanted to start with the idea of what might trauma-informed and gender-responsive work with men look like. And here I'm just quoting from a chapter from the book that I edited by two men from the U.S. who wrote a chapter called Embracing the Boy Inside the Man, Trauma-Informed Work with Men. And they, talked about these principles of trauma-informed practice and how they may play out somewhat differently for men in the context of our work. And In terms of safety and trustworthiness, they recommend really empathizing with this disconnection that may exist for men between their identity as a man and their experience of powerlessness. And certainly some of the Canadian men who have come forth as victims of sexual abuse, like Sheldon Kennedy, have really talked about that disconnection, making it really hard to come forth, because there's this, on the one hand, your masculinity and your, being powerful as a hockey player, and on the other side, this experience of powerlessness within an abusive relationship with someone you should have been able to trust. So really thinking about that is an important part of it. And that idea of skill building that, for everyone, but especially for men as well, that idea about teaching about expression of emotions, of not necessarily of having had a lot of early learning or positive experience in terms of attachment and or learning of different emotions beyond being angry or sad, and really teaching that. And those of you who work in addictions treatment know just how important that can be for people with substance use problems as well, and in terms of the work on feelings. And the third thing they mention is really that idea of collaboration as being a really important one, and that men who have been sensitized to abuse of power in relationships may need to hear offers of collaboration repeatedly, not just once, but lots of opening to collaboration. And finally, really acknowledging where relational skills exist. It can be especially important for men, and they feel like, as they say, water in the desert for male survivors. So really, I think a really interesting chapter and thinking around trauma-informed, gender-responsive work with men. There's been quite a lot written, too, about trauma-informed approaches with boys, both by this one group on the left-hand side, the ROCA group in Boston, and also on the right-hand side, this work from the Drexel University and the Center for Nonviolence and Social Justice. But, key to it, I think, is really interesting. If you notice at the bottom of the left-hand side, some of ROCA's strategies include really trying to make transformative relationships or transformational relationships happen, emphasizing that relational thing is important, and teaching peacemaking as opposed to violent ways of responding. And I think that's a really interesting take on trauma-informed work that may give us some ideas of the work with boys and men. On the side of girls and women, there's been actually a lot more written, and I'm just really recommending this particular manual from the Jean Tweed Center in Toronto, who is a very thick manual with their learnings over a decade of work in bringing trauma-informed practice into treatment and outreach with women with substance use concerns. And it is just a work of art, really worth getting and reading on their understanding of what it is to be empowering and avoid re-traumatization with women with trauma histories and substance use concerns. And they've done a lot of great work in staging trauma and including trauma-specific work post-treatment and trauma-informed work in the outreach and early treatment experience. And I think have contributed a great deal to our understanding of that staging and that creating of safety and relationship first. Another, great contribution, I think, to understanding trauma-informed practice is this work that's been done by Colleen Dell and others in terms of the views of Aboriginal women in treatment in Canada. And this was a project that they did in terms of asking women in substance use treatment who'd been in conflict with the law and had a lot of other struggles in their lives about what they'd like to see from their treatment providers. And again, I feel they've made a wonderful statement of trauma-informed practice in their answers to that, and they're summing it up by this word reclaim. But you'll notice as they're interested in their service providers being empathetic, being non-judgmental, being inspirational, communicating, and all these other things, that's central to what they want from a service provider is the recognition of the impact of trauma in women's healing. And I think it was, it's a tremendous statement of how important this is in the context of work on related issues. And those of you who haven't actually watched the video clip from Stilettos to Moccasins, that is just a lovely visual of their thinking on this. And most recently, Colleen has been working with an elder and many other researchers, both Indigenous and non-Indigenous researchers, on understanding culture as intervention in healing from addictions and trauma and related concerns. And I really encourage you to have a look at her website and some of the stuff that's coming up on that website as clearly trauma-informed interventions that are cultural in nature. It's just been an amazing process that I've had the privilege to be a part of in terms of thinking this through. So questions again on the on this aspect of it. Just trying to I'm just going to close down this part so I can see the questions a bit better. So I don't see any more on these particular issues. Lots of things to think about, eh? It's piling on the different aspects of trauma-informed care. And once again, I just want to mention these pictures that are on the question pages are posters that we're piloting in British Columbia as ways of indicating that trauma-informed practice may be happening in a service. And so they're trying to think, instead of all the signage within the first waiting room of don't do this, no smoking, no violence, and no all those kinds of sort of more intimidating type approaches, is to think about what kind of things might be in a physical environment that would signal to clients that this is a place where this kind of connection and respect for culture is taking place. Okay, the one last section here is one I feel really passionate about. You've probably heard my voice. I feel passionate about it all, but this part of it is, I think, really important for the system to get. This work on trauma-informed practice at the organizational level, and that it matters that our service cultures are trauma-informed and that we're working, across agencies and systems with each other in a trauma-informed way as well. So I'm just going to take a minute or two to talk about some of the aspects of that. One of the things organizations have been doing is using a kind of a checklist method of going through their policies and hiring practices and the way they support staff and their procedures, their assessments and intake procedures, and et cetera, and asking themselves some questions about how they might bring trauma-informed approaches into this work a bit more. So, you know, the BC Trauma-Informed Practice Guide that I showed a picture of earlier definitely has such a checklist within it, and that is certainly one way of going about it that people have found helpful. And many organizations have used staff meeting time to do it over time. Many others in British Columbia have built, you know, sort of cross-agencies, communities of practice where they've collectively looked at some of these issues together, learned together, shared ways of coming at it together. So lots of things to do in terms of thinking about the implications at the agency level. Just wanted to mention this work of Sandra Bloom's and the sanctuary model. She's written a great deal on what trauma-informed organizational cultures look like. And I think it's, you know, for those of you who are into reading on organizational culture, it's fascinating. And she's, you know, she really talks a lot about how, as an agency and interagency way, we can be working as curious people together, learning together, talking about these things together, and working in ways that don't perpetuate you know, traumatizing and sort of more violent ways of working with each other, and avoids lateral violence and all that that kind of territory. So I think she's got lots to say, and for those of you who, you know, may not want to come at this from the kind of checklist approach, but from a more sort of reading together and reflecting together kind of approach, her work is highly recommended. But one of the things everybody's been quite keen on, I think, is to understand how to deal with the issue of secondary trauma, the kind of trauma that you may experience, and in this case from child welfare workers. Some of these kinds of symptoms of trauma as workers, just from the exposure to a lot of clients and very difficult lives. And I think it's kind of interesting that there's been, you know, the work on trauma-informed practice has really brought this forth for us, that this is important for us to be thinking about and talking about. And here's an example of professional impacts of secondary trauma, sort of organized like we did earlier on in terms of the clients, you know, here's what it might look like in terms of interpersonal impacts or behavioral impacts in the context of the workplace. So lots to think about. And again, like with clients, it will really vary depending on your personal experience of trauma or your own support, the degree of support in the workplace, et cetera. So, you know, it's not a given that everybody will experience trauma, but it's important for us to acknowledge that that when we work with clients with trauma histories, we ourselves need to think about how we're taking care of ourselves. On the, you know, one study that was an interesting one in BC, I think, was one about, you know, identifying all these various things that can be done as protective practices to avoid trauma or secondary trauma. And the first one I just want to talk about for a minute, which was that many service providers they interviewed found that it wasn't the exposure to trauma that was was the problem. It was the lack of ability within the context of the service to have an empathic engagement that, you know, whatever the policies or procedures or whatever that got in the way of, you know, creating the possibility for an authentic connection was more the problem in terms of secondary trauma than the actual exposure, which is kind of an interesting take on it. Many people have talked about the importance of attending to our own self-care and to have adequate time within our services to de-stress and to debrief, as you saw in some of those examples I gave earlier of the hospitals, really honoring the need to debrief and have the chance to talk about issues that were going on in the workplace. And many people have written about, you know, how we individually can be well as practitioners, really being aware of our needs, really balancing our work and other activities, and really honoring that we need to create opportunities for connection to ourselves and to others and to something larger. Beyond ourselves. So, you know, that ABC model is well liked. But I also think there's a responsibility of whole agencies to think about how, instead of putting it only on the back of the worker to be well, is to really think about how we support wellness and resilience across our agency. And here's an example of an intervention that was done in the child welfare area where they involved child protection specialists, supervisors, managers, and deputy directors, all in collective learning together and learning to apply emotional regulation and other resilience-related skills. And they've been doing this in this agency in New York for some time now, and really noticing in their evaluations that people do feel more supported, and there's a lot less negative perception of themselves and their work when this kind of collective engagement with resiliency and collaboration and optimism is supported. So I think, you know, that this organizational part of the work cannot be, you know, overestimated as important. So, yeah, somebody's mentioned that it is a lot to reflect on, and I think that is definitely the story, and I feel kind of guilty pouring so much out here for you to reflect on in such a short period of time, and I hope that, you know, it will be something that gives you some food for thought, and really thinking about the first responders as well. I think that's a really important group of people, and I know that there's been some work done in British Columbia amongst the first responders, and I assume in other provinces as well, and really thinking about their health and well-being and how we can support them to not experience vicarious or secondary trauma as well. So the leaders, I didn't want to kind of leave the system leaders off the hook and really kind of sum up by talking about this as a system-level initiative. And I think that, you know, things like you're doing today and that Betty Ann's supporting today about building, a larger learning culture about trauma and providing forums for training and learning is absolutely central. We're not necessarily talking about a whole bunch of new services or new money as much as we're talking about a paradigm for working differently, and that requires us to come together and learn together and ask some hard questions questions and about the way our systems work now, and involving children, youth, families, adults in helping us create safer, kinder systems of care, for sure. And one of the things that's really been noticed when people have done system-wide work to integrate trauma is that having what they call trauma champions has been really helpful. People who actually take forth these discussions within the context of their agencies or regions, and to promote change has been really really helpful. So, making it part of the job of some people to continue to discuss and to educate and to learn and adapt and rethink and support each other has been really helpful. And I think there's really a strong need for leaders in multiple systems to think about how we share trauma-informed resources across systems and create a kind of a trustworthy service network of support and treatment, not just system by system, but really multiple systems doing this together. And when that happens, it makes it easier for all, I think, in lots of ways. So I've thrown a lot of things at you this morning, about practice and system designs and the importance of us really thinking about leadership and in it. And all in all, I guess I recognize what a tall order it is in some ways, and requiring a lot of complex thinking, and at the same time being fundamentally doable and profoundly simple to put in place. So, I think that idea of collaborating and spending more time thinking about what the quality improvement might be and how we will make adaptations as we go forth to our systems of care, and how we know whether this has been successful. It's been so, helpful to me as I've been thinking about this and advocating for it, that many people have gone before us and created manuals and done research and shown us the evidence for how helpful this can be. And I guess I just kind of want to leave on that note that I think it is incredibly hopeful that this work has been done, and that there is interest by all of you who've taken the time to listen in today and to create all kinds of other ways of learning together across Canada. And really that there's been a lot of great contributions by survivors of trauma as well, including some of them that have organized conferences called Grounding Trauma, et cetera. That's been really given us lots of ideas about what's important. And, and people like the people in SaskHealth and other systems who've, in Saskatchewan, who've organized the session today, I think really so interesting that so many provinces and territories in Canada are really taking this head on and creating actual statements within sexual violence plans or mental health and substance use plans and child welfare system plans, et cetera, to really think through and get on the page about what kind of guidance will help all of us as we go forth. So I think we've got a couple more minutes for questions if there are any, but I've come to the end of my massive number of slides. So if there's anything else people want to raise at this point, let's do so now.
Nancy, it's Betty Ann, and I just want to say this has been tremendous in terms of the scope of information you've provided, and and the opportunity for people to ask you questions and try to get some more understanding. I agree with you. I think this is tremendously important information for people to understand in terms of how we move forward to better interact with people we serve, but also it helps us understand some of our own reactions in our own personal situations sometimes, or those around us. And so I think this sort of information is just so useful in so many ways, and it helps us move in front of the symptoms to understand more about the root causes of some of the problems and some of the situations that people are dealing with. So I just want to say this is tremendously good information, and I thank you so much for taking the time to provide this and all the resources and all the examples. And I also just want to thank everyone on the line for participating today.
That's great.
Comments?
That's great. And Betty Ann, I just want to mention that we will have these slides up on the Center of Excellence's website, as I mentioned, after the third in the series, because we're doing 3. There were so many of you. There's over 600 people who wanted to do this learning. It's so interesting and terrific. So we will have them up, and I will create a whole range of resources and make sure they get posted as well up on our website, so that you can see where to connect with some of these great manuals and things that I've just shown pictures of today as we've dashed through. So both of those things are possible, and I just want to say to people that you will get, I think it's a 3-question evaluation that we'd love you to comment on, and to, and that could be a way of signaling some other learning needs that you might hope for in the future as well, so that as well as evaluating this one, really giving us some ideas about what's important going forth. And to me, that's the way we make change, is by speaking up and saying what's needed. So the slides will be available, I would say, I think the last one of these series is on the 28th, Betty Ann, so at the last, I think it's fair to say we could get the slides up on the 30th of April.
That would be wonderful.
Great.
Okay, well, thank you all again so much, and you particularly, Nancy.
Right on. Bye for now.
Bye-bye.